We'll start today the tumor of the oropharynx. Before starting the class, we'll recapitulate the little bit anatomy, which will be helpful for discussion of the tumors of the oropharynx. Now, oropharynx, the limit of the oropharynx from H to H, or it's from the, it is from the hard palate to the hyoid bone, and the oropharyngeal isthmus, that is the communication between the oral cavity and the oropharynx. The oropharyngeal isthmus, this is the oropharyngeal isthmus. The oropharyngeal isthmus is above bounded by the soft palate, and it is below by the dorsum of the tongue at the circumvallate papillae, and it is laterally bounded by the anterior pillar of the tonsil. This is the oropharyngeal isthmus. And now the boundaries of the oropharynx, the boundaries that you see, that is the posteriorly, it is bounded by the fascia, retropharyngeal fascia, and then the vertebra. The vertebra means the second cervical vertebra and upper part of the third cervical vertebra. And anteriorly it is bounded by the base of the tongue, and that is the base of the tongue. There is some papilla and lymphoid follicles are there. There is the foramen cecum, sulcus terminalis, this is the circumvallate papillae. And here is also another thing, that is the tonsil, that is the lingual tonsils. The vallicula is the space. It is the space, is the posterior surface of the epiglottis, and the vallicula, the space is divided by the glossoepiglottic fold and laterally bounded by the pharyngoepiglottic fold. The vallicula is important for the extension of the tumors of the oropharynx, especially the base of the tongue. The lateral wall, you see this is the lateral wall by the tonsils, and we'll get the anterior pillar and the posterior pillar. That is the tonsils, the anterior pillar, here is the posterior pillar. This lateral wall and the lower boundary consists with the continuous with the hypopharynx, and the pharyngoepiglottic fold, upper boundary of the epiglottis, that is the lower boundary, is formed by the mostly by the epiglottis, and the base of the tongue, the vallicula. Now, the important thing another is the lymphatic drainage. The main lymphatic drainage is the jugulodigastric chain, and the tonsil is directly drained into the jugulodigastric, the soft palate and the posterior wall of the oropharynx are drained into the retropharyngeal node, sometimes the parapharyngeal node, and then ultimately in the posterior group of the cervical lymph node. The main thing is that is the lymph node in the digastric and the sternocleidomastoid region, and the importance is that the base of the tongue is bilaterally drained. The draining of the lymphatic of the base of the tongue is bilateral. Now, the function of the oropharynx, it is the conduit of the food, or is the introductory point of the food bolus. It helps in the pharyngeal phase of the deglutition, and sometimes it is helps in the producing some speech sounds. Now, what is the local defense? Local defense is composed by the Waldeyer's ring. I think in the last exam, there is some question, whether I cannot properly remember, there is by the Waldeyer's ring or some adenoid. The Waldeyer's ring is the laterally the main D tonsils, and above there is the adenoid, and at the base is the lingual tonsils. This is a lump of lymphoid tissue under the epithelium, and it is not an organized lymph follicles or lymph node. I have asked 2 or 3 students the difference between the tonsil and the lymph gland. The minimum the difference is the afferent and efferent in the lymph gland, and tonsil has no afferent, there is only efferent. They cannot answer it. I don't know why. The very basic question. And B lymphocytes are present in the center of the follicles, and these lymphocytes are responsible for production of the IgA. The T lymphocytes or the killer cells are responsible for the cell mediated immunity and the destruction of the cells. And other pathogens which is introduced into the lymphoid tissue, they are tackled by the IgM and IgG, the immunoglobulin. This is in very nutshell, that is the part of the anatomy of the oropharynx, the lymphatic drainage and the function which is very much required for the discussion of the tumors of the oropharynx. This is the tumors of the oropharynx. First, the benign tumor, the papilloma. Papilloma, it may be sessile, it may be pedunculated. And it is a benign tumor. Sometimes it is smaller enough, they can produce the symptom. But when it produces the symptom, difficulty in the swallowing, irritation of the throat, you can excise it out. This is the papilloma. This is the papilloma here. You see, this is the base of the tongue. It is the tonsillolingual sulcus. This is the base of this is the papilloma. And then there is a hemangioma. Hemangioma may be 2 types. There is a cavernous hemangioma or a capillary hemangioma. The main treatment is sclerosing agent. You push the sclerosing agent. The cheapest sclerosing agent is the hot saline. And nowadays, so many modern sclerosing agent is used. And surgery, we prefer generally the cryosurgery to formation of the ice by the carbon dioxide, and the dry ice is formed and is automatically, it will be separated from its mother tissue. Next is the pleomorphic adenoma. Pleomorphic adenoma is the submucosally in the hard palate. This is a picture of pleomorphic adenoma in the hard palate. The pleomorphic adenoma, there is the chance of malignancy in the pleomorphic adenoma in the hard palate is very common. So, you excise it broadly. Next is the mucosal cyst. It is an accidental finding. Sometimes it is over the tonsil, sometimes it is, it may be in the epiglottis or in the vallecula. And most of the time it is not producing any symptom, accidental finding. But if it produces any symptom like there is irritation, the chronic cough, difficulty in the swallowing, then you should excise it by micro technique or micro laryngoscopy or micro hypopharyngoscopy. Then lipoma, fibroma, you can, this is also available. And next to the, this is papilloma. Now coming to the malignant tumor, and according to the site, the common site is the base of the tongue. Yesterday, before taking your class in SGT, a group of the students in SGT, I have attained a patient in that is known as the isolation ward beside the emergency, and I have seen a almost 50 years aged patient and who was treated outside, and the ENT surgeon of Bolpur has do a microlaryngoscopy, take a biopsy from a suspicious zone of tongue base, and then it is sent for the histopathology. The histopathology is almost, it is a superficial ulcer, and there is a multiple neck glands, and the FNAC done by someone, it's written in, on a pad, by handwriting is there, and it is written that is a granulomatous lesion. Now, the ATD or the antitubercular drug was started, but gradually the patient is deteriorating and the body weight is deteriorating. Now, there is no report for the sputum, CBNAT, and then I cannot see the larynx in the ward because there is no scope for the indirect laryngoscopy. So, I advise the patient to come in the outdoor today, and I have seen there is a multiple limb gland and it is soft to far bilaterally, and I advised ultrasonography of the neck and FNAC from the ultrasonography guided FNAC at our medical college, and I asked for the wax cube of the tissue taken from the tumor or the base of the tongue or the suspicious area of the base of the tongue, and I advised a ultrasonography of the whole abdomen with a suspicion that there is an entity I will describe you, that is the lymphoepithelioma or the lymphoma. There is a lingual tonsil, there is a lymphoma can be happen, and in case of the lymphoepithelioma there is a not differentiated properly a squamous cell area, and which is there is a huge number of lymphoid tissue, with the suspicion that we will repeat the histopathological study from the wax cube. We will take the microtome slice, and again our pathologist will examine that thing, and we ask for the CBNAT. Here we have a known young microbiologist here, and I have done the ultrasonography of the abdomen to see is there any limb gland in the intra-abdominal. We have got the X-ray chest, but there is no mediastinal enlargement, there is no exact comment about the enlargement of the limb gland in the mediastinum or not. This up to this the patient is there, but the patient is very cachectic, very toxic look and reducing his body weight. My suspicion there is some malignancy in the base of the tongue, and that may be lymphoma. There is a multiple limb glands is there, and which is not hard like a metastatic gland. Next is the tonsil and tonsillar fossa, the phoceal palatine arch, that is mostly the soft palate and posterior pharyngeal wall. Now, malignant tumor, the gross appearance, if you attain the clinical classes in ENT, there is a one, I joined in the medical college 2.5 months, I have seen 1 or 2 cases of the tonsillar malignancy, and it is a superficially spreading ulcer, superficially spreading. The biopsy report or the histopathology report from outside of that patient was there is an ulcer, A superficial ulcer, there is a chance of superficially spreading ulcer. Exophytic, that means it is growing outside. Growing outside. Ulcerative, that means the gross. Mostly you have seen the ulceroproliferative growth, mostly, and it is very painful. Infiltrative, someone is infiltrative, it is infiltrate to the deep muscles of the tongue, it infiltrate to the parapharyngeal wall or parapharyngeal spaces. Now, what is the classification, the malignant classification according to the pathology? The squamous cell carcinoma, the three types is there. There is a well differentiated, moderately or poorly differentiated. The poorly differentiated squamous cell carcinoma, and then there is, I have already told you, that is the lymphoepithelioma, and then the adenocarcinoma, and lastly the lymphomas, maybe the Hodgkin's or non-Hodgkin lymphomas. Okay, that is the tumor classification. I will come later. And this type of okay, let's see. What is the treatment? Depends upon the site and extent of the disease. Here the classification is needed. Extent of the disease and finally the experience of the treating surgeon or the team, that is the tumor board team, that is composed by physician, that is oncologist, surgeon. The option treatment is surgery alone, radiation alone, or surgery and radiation is a sandwich program. Sometimes the chemotherapy also added, chemotherapy, surgery added, and palliative therapy. What is the palliative therapy? When it is beyond our scope. There is a massive metastasis of the neck gland, metastasis in the liver, metastasis in the bone, and the general condition in patient is very, very poor. And what is the palliation? To reduce the pain. Generally morphine is used for reducing the pain. And nowadays, now we giving there is a fentanyl patch. We are giving the fentanyl patch and it will continue almost 24 hours, a single patch. And we go for the tracheostomy to maintain the airway and feeding done by the gastrostomy tube. That is the palliative part of that whole treatment when it is beyond our hands. Now, carcinoma base of the tongue, why it is important? Because its percentage of occurrence is highest for the carcinoma base of the tongue. Not only that, in our postgraduate period, we have got a long question very frequently, that is known as the primary occult. That means there is a limb gland, that is a metastatic limb gland, but we cannot find the primary. We search for the nose, the nasopharynx, oropharynx, and the base of the tongue. This malignancy, the tongue-based malignancy, is the primary focus, 50% cases of the primary occult. So, it is hidden, there is no symptom, just a irritation of the throat, pain, not more than that. The physician advised warm saline gargle, paracetamol, antibiotic, everything. The earliest symptoms, sore throat, filling lump, throat defect, and late features. When it is involved, the structure outside the base of the tongue or the extrinsic and intrinsic muscles of the tongue, and it is involvement is the palate. It is involvement in the pillar and it is involvement in the pterygoid muscles, pterygoid plate, and then the features coming. Referred pain, dysphagia, bleeding from the mouth, change in quality of the speech. It is known as the hot potato voice. Now, another thing also happened when the pterygoid muscles are involved, that is the trismus. That is the growth in the base of the tongue, exophytic growth of the base of the tongue. That is gradually increasing and occluding the foot passes. What is the sprayed? Local sprayed, tongue musculature, epiglottis, pre-epiglottic space, tonsil, facial pillars, hypopharynx, lymphatic sprayed. Already I have told you it is a bilateral lymphatic sprayed. So 70% cases show the cervical metastasis either unilateral, bilateral at time of consultation. Jugulodigastric nodes are fast to be involved. এই নামা এটা নামাবো ওটা এরকম হচ্ছে কেন ওপরে 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 বাস 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 distant metastasis bone liver lung carcinoma base of the tongue. It is diagnosed. One thing, when you see there is the oropharyngeal ulcer or ulceroproliferative area, one thing you should do by wearing a gloves, you should palpate. By palpation, you can be confirmed, you will gather the experience, you can confirm that is a malignancy. And it is involving the outer structure. Palpation under anesthesia, the CT scan is needed to see the neck nodes, FNSE of the neck nodes and the biopsy. Now, the carcinoma base of the tongue, posterior 1/3, lymphoepithelioma, that's a blessing. They are radiosensitive. Mostly the lymphomas are radiosensitive. That is the blessing. And T1, T2 squamous cell carcinoma. T1 means 2 centimeter, not more than 3 centimeter. T2 means it is T2 and squamous cell carcinoma N0, N1 neck, the surgical excision with a block dissection. When there is a neck dissection, when the lymph gland is there palpable and by biopsy it is proved it is a metastatic lymph gland and we go for the block dissection. And not only the block dissection, with a suspicious, it may be present with the opposite side, we go for the, or it is some non-palpable, not remarkable node, then go for the radiotherapy. T3, T4, it is almost in the stage 4 level. We go for the Commando Operation. That will, the hemimandibulectomy is done and directly go to the pharynx and removal or surgical excision and then the radiation. T4 lesion. T4 এর মধ্যে আবার T4A and B আছে according to the invasion to the pterygoid muscles, the outer muscle structure. Then in T4 lesion, anterior tongue, the vallecula, extensive surgery. And in that case, sometime we do not go for the hemimandibulectomy. We go lateral pharyngectomy. Laterally, we cut the pharynx and expose that area and excise the whole thing. The larynx, that is the laryngectomy and the pharyngectomy both. And then by the flap, graft is given either by the pectoralis major or from the radial flap. And in that case, the last case, that is the stage 4 cases, we added that the chemotherapy, adjuvant chemotherapy and the radiotherapy also. And the tonsil and tonsillar fossa, in base of the tongue, that was mostly the lymphoepithelioma. But in case of the tonsil, it is a squamous cell carcinoma. It may be well differentiated moderately or it may be poorly differentiated. The poorly differentiated one is very much radiosensitive. It is ulcerated necrotic base. The lymphomas present unilateral tonsillar enlargement and mimic the squinsy. Sometimes there is a question for the unilateral enlargement of the tonsil. The first thing you suspect, according to the age, whether it is a malignancy or not. Because the lymphoma happen in lower age group also. So it may be a lymphoma, and lymphoma is not a ulcerative lesion. It is an enlarged lesion, and lymphoma sometimes mimics with the quinsy. That means the palate, the soft palate area is swelled and it is red in color, and the tonsillar surface is irregularly enlarged. It a raggy appearance. The appearance is, it's not a very good looking. It's not like a follicular tonsillitis. It is separate appearance. This is the ulceroproliferative area of the tonsil. This is the ulceroproliferative area. And this is the lymphoma. You see, the appearance is not so ugly looking, the smooth, only there is the crypts are filled up, not by the pus, but by some tissue, the soft tissue. If you palpate, that is firm to hard in palpation, and the whole tonsil you can palpate. Local spread, soft palate, pillar, base of the tongue. But one thing, the lymphoma generally not spread like a squamous cell. It's not invade a ulcerative part in the palate, in the pillar like that. But the lymphoma present mostly there is a enlarged, hugely enlarged tonsil with a lymph gland outside. That is the presentation. It will involve the soft palate, the pillar, base of the tongue, pharyngeal wall, hypopharynx. That means it is outside the limit of the tonsil and the pterygoid muscle, even the mandible. The lymphatic, the 50% patient have initial cervical node involvement at the time of presentation, and that is the jugulodigastric gland. Distant metastasis is seen in late cases. Clinical features, once and again, diagnosis, so one part of the clinical examination, the palpation and the biopsy. The clinical persistence, throat pain, dysphagia, and every time you see, that is the earache is there. And that is a neuralgic pain. Not only that, it involves the eustachian tube, block that eustachian tube, that is an AOM like that, not like that. It is a neuralgic pain. As the involvement of the surrounding area, the supply is the same. There is the trigeminal nerve, the supply, the earache is started. The neck swelling, the trismus. I have already told you the trismus is by the involvement of the pterygoid muscles. Medial pterygoid, lateral pterygoid, pterygoid plate, everything. And what is the treatment? In case of the lymphoma, very satisfactory treatment by the radiotherapy. Certain level, up to certain level, the surgery. In case of the ulceroproliferative growth, if it is a big growth, then it is involvement of the bone, involvement of the mandible, we go for the Commando Operation. That is the hemimandibulectomy. You remove the whole tonsil and the involved tissue and then go for the reconstructive surgery by the pectoralis major or by the radial flap. Can you tell me which artery is anastomosed by this type of flap operation? Already Professor Ognivo has teach you regarding the laryngeal surgery and reconstruction, I think. হয়ে গেছে ক্লাস? অগ্নিভূ স্যার পড়ায়নি ল্যারিঞ্জিয়াল ম্যালিগন্যান্সি? সবাই মাথা নাড়ছে, কোন দিকে মাথা? তো ম্যাড্রাসিদের টাইপের হয়ে গেল, পড়ানো হয়নি ল্যারিঞ্জিয়াল ম্যালিগন্যান্সি? আচ্ছা, দেন the beautiful thing, there is a during the block dissection of the neck, suppose there is a excision of the submandibular gland in submandibular stylobadenitis, we will dissect, first ligate the facial artery in 2 times. Below, when it is coming from the external carotid artery, underneath the digastric belly, there we ligate, and again ligate near the lower border of the mandible during the submandibular excision. But if in case of the block dissection, it is a simple block dissection, then we cut the facial nerve. But if we consider a reconstructive surgery, such in case of the Commando Operation, then we will dissect the whole facial artery, remove the other part, and the anastomosis of the radial artery, which is with that flap, radial flap, or in case of the pectoralis major, that is the branch from the thoracocervical trunk, we anastomose it with that facial artery. So, facial artery is important, and we will keep the facial artery intact for that reconstructive surgery. Now, what is the combined therapy? All I have told you, and mostly nowadays it is a combined therapy is going on, that is the chemotherapy. Nowadays chemotherapy is not like a cisplatin, all these things, old medicine. Nowadays chemotherapy is targeted at different point for the which are responsible for the death of the cancer tissue. Sometimes some drugs attached to the target point, and it attracts the other drugs, which is causes the death of the cancer tissue. That chemotherapy is hugely revolutionized nowadays. And then there is a radiation or radiotherapy, that also it is improved far. Now there is a in our time that is a was the cesium therapy, and the whole thing is burned, the black, and the mucositis, continuously the salivation, patient continuously complaining of throat pain. Now, then coming the cobalt. And now there is a cone radiation, and different type of process of radiation is evolved, or it is invented, and the surgery also developed. In similar way, surgery also developed. What is Commando Operation? It's the combined oromandibular reconstruction, resection and reconstruction. That means the incision is given over the chin, round the oral cavity, and this flap is out. Then by the saw, this mandibular part is rotated, either rotated or it is cut through and through from the angle of the mandible, and we have get the space, wide space for the tonsil, and the parapharyngeal tumor or the malignancy of the pharynx, and we have removed it. Then the reconstruction is done by the mostly by the fibula, and the fibula, and either from the radial flap or by the PM flap. Carcinoma of the palatine arch, this is also common. The tonsil are not involved, complaining of pain, and consulted the dental surgeon several times, but when you find there is almost a ulcerative growth involving the anterior pillar and the soft palate. Most common tumor type is the squamous cell carcinoma. This area, it is in the tonsil and pillars of the tonsil, that is a squamous carcinoma. Main sprayed condition structure is the lymph node, present persistent with the pain, local pain and earache, treatment is irradiation and the surgery. Carcinoma of the posterior lateral pharyngeal wall, and the lesion remained asymptomatic for the long time. It is behind the posterior pillar. If you depress the tongue, not always it is visualized, otherwise you think about that lesion. It is a very small ulcer sometimes. It is a painful, or it is covered with some slough. Why it is slough? Posterior to the pillar. Oh, say this is a small ulcer, you go for the antiseptic mouthwash, antibiotic and the painkiller. It's nothing like this. But you should palpate it. Even I will say there is several times you will see the painful, the oral pain, and you open the mouth, you will see a big ulcer on the lateral margin of the tongue. It is also happened in our case also. If the teeth is sharp or the teeth is broken, that causes the multiple puncturing over the tongue and causes an ulcer which is very much painful. But before referred he or her to the dental surgeon for the extraction of this tooth, you palpate that area. The induration, the ulcer palpation will teach you the feeling about the malignant change, and which is before the histology. They may also involve the parapharyngeal space and anterior spinal ligament. If the anterior spinal ligament is involved, there is a chance of torticollis or neck pain. Sometimes there is a parapharyngeal space. I have already take the class for the deep neck space infection, and similar type of symptom is produced if it is involved the parapharyngeal space. Bilateral involvement or the nodal involvement and treatment is the irradiation or the surgery. The radiation or the surgery. The parapharyngeal tumor is what can be happen, that is a deep lobe. You will not see any ulcer. Only the posterior to that posterior pillar or the tonsil is protruded medially. That may be due to the deep lobe of the parotid. There is a malignancy, there is a pleomorphic adenoma involving the deep lobe, and it will push the whole lateral wall of the pharynx medially. Neurogenic tumor, that is the neurolymphoma, or chemodectoma, that is the carotid body tumor. Carotid body tumor or the glomus tumor, you can delineate this tumor by the DSA or by the CT scan or MRI, the lipoma. You see, this is the anatomy. This is the parapharyngeal space, and it is the tumor encroaching here, and it is pushing. It is the uvula there. It is the base of the tongue, circumvallate papillae, and it is pushing one side. Tumors of the deep lobe of the parotid. You see, this is the uvula. You can say it is a quinsy. If you palpate, then you can differentiate it from a quinsy. Now we back to the do you know the Eagle syndrome? Anyone? Eagle syndrome is the pain in the ear and which is radiated to the neck, in the throat, and it is sometimes it is called, it is due to the glossopharyngeal neuralgia, and sometimes said it is due to the elongated styloid process, or it may be due to the ossification of the stylohyoid membrane in the later half of the life. How can you diagnose it? You will diagnose it by an X-ray, that is the X-ray skull epi view in open mouth, or it is known as the reverse Townes view, or it can be done by the OPG, orthopedic tomography, that is the OPG, or by the CT scan. Normally, the styloid process is 25 millimeter in length. When it is more than 30 millimeter, then we call it a styloid elongation. But that is not the sufficient. You should palpate through the tonsil. If it is palpable through the tonsil, then it is the case for the surgery. You go for the tonsillectomy, you separate the superior constrictor in the bed of the tonsil and you see the elongated styloid process. You cut the elongated part of the tonsil and that will reduce the pain. That is the Eagle syndrome. It is not related with that, but sometimes the pain not due to the tumor or anything, that may be an Eagle syndrome. Now, the classification almost the same for the TNM classification. It is said that in the TNM classification, overall staging of the oropharyngeal tumor, that is the T0 is nothing, carcinoma in C2, and T1 is 2 centimeter less than or less. T2 is the 2 centimeter but not more than 4 centimeter. T3 is the more than centimeter. T4 tumor invades the adjacent structure. That means the significant part in our case for the surgery is the T3 and T4. In case of the T1 tumor, T2 tumor, according to its character, if it is a lymphoma or it is a lymphoepithelioma, we can consider the radiation. That is again the node. Here, in case of the tumor, it is 2 centimeter to 4 centimeter. When you go for any TNM classification, you should maintain that thing, that in case of the tumor, the dimension is 2 to 4, but in case of the node, it is 3 to 6. N1, metastasis in a single ipsilateral lymph node is 3 centimeter or less. 2, metastasis in a single ipsilateral lymph node is 3 centimeter. 2A is the ipsilateral node. And you see that is the N2A is the metastasis is single ipsilateral node more than 3 centimeter but not more than 6 centimeter. 2B is the metastasis of multiple ipsilateral. 2B is the multiple ipsilateral and 2C is the bilateral or contralateral. If it is a contralateral, that is also 2C. And it is more than 6 centimeter. And N3, the metastasis lymph node more than 6 centimeter in greatest dimension. That means in case of the 2, it is not more than 6 centimeter. When it is ipsilateral, it is 2A. When it is bilateral or contralateral, it is 2B. And 2C is the bilateral contralateral lymph nodes not more than 6 centimeter is 2C, and N3 is above C, 6 centimeter. That is N. Now, staging depend upon, and that is the distant metastasis M0 and M1, present or not. That is M0, N1. And according to the staging, stage 3 always with lymph node, T1, T2, T3 all with lymph node, N1. And stage 4 is 4C, always the metastasis is possible, distant metastasis. So, this is the classification, and according to the stage, the treatment schedule is depends, and mostly Nowadays, when the radiation in case of the lymphoepithelioma or the lymphoma, the smaller size, even with an egg gland ipsilateral, but in case of the squamous cell carcinoma, if it is very restricted, then the radiation only possible, otherwise go for the extensive surgery and the neck dissection. If the bone is involvement, going for the commando operation. And after all efforts of the surgeon or the oncologist, the treatment is the palliative. That is our last resort.